Welcome to MedEd's production of the Certification in Pediatric Emergency Nursing Review course. My name is Melissa Weir, and this module is on neurologic emergencies. In this module, we will focus on the intricacies of the developmental milestones of the pediatric patient and assessment techniques that are needed for the pediatric patient that presents with neurologic emergencies. The objectives of this module will be to identify key elements of the neurologic assessment, identifying developmental milestones and neurological variations, identifying signs and symptoms of increased intracranial pressure and herniation in the pediatric patient, and assessing and intervening with specific pediatric neurologic medical, surgical, and traumatic emergencies, including meningitis, encephalitis, Guillain-Barré, spinal cord injury, and AV malformations. The first two slides that we'll look at are just some of the major motor milestones in dealing with the pediatric patient, starting with the newborn and the infant. It's important for the emergency nurse to have an idea of when a child should normally meet these milestones, so that during the assessment, if they are not meeting these milestones, you know to either evaluate that could be related to a presenting illness, or it could be significant and indicative of a developmental delay that was not noticed prior. For example, any baby that's 3 to 4 months, their movement should be a little bit more coordinated compared to that of the newborn infant. All infants are born with the reflex of grasp, but by 3 to 4 months, grasping for objects is definitely intentional as compared to the neonate. By 8 months, this infant should be pretty well versed at rolling from supine to prone position and even transferring things from one hand to another. I skipped over 6 months, but that is a very important milestone where babies at that point should be able to sit independently, although with some support, propped up, but they should definitely be able to sit and hold themselves up and not roll over. By about 12 months of age, we expect this baby to be able to stand independently, and at that point, some babies will even walk with support. In addition, we have the primitive reflexes that, again, one should be aware of, because if a baby cannot demonstrate that they've met these reflexes, it absolutely is consistent with some type of delay. And it could be a cognitive, it could be developmental, it could be a physical problem that's contributing to the delay. So, for example, the Moro or startle reflex, evident at birth, and basically when you startle a baby, you can clap over their head or shake something really loud in front of their face, and basically what they're going to do is open their hands, extend and abduct their upper extremities, and then flex their arms back in. And that should really happen up until 6 months of age. The tonic neck reflex, also present at birth, goes away at about 6 to 7 months of age. Whatever side the infant's head is turned to, they're going to extend that arm and bend that leg. And this is actually also called the fencing reflex, because that's the position that they look like they're in, like they're actually fencing. The palmar or grass reflex, again, very evident early on. If you place a finger in their hand, they will naturally just curl their hand around and tighten their hand around when you attempt to withdraw, and that will disappear at about 8 months of age. And then, of course, the Babinski. Babinski is very significant in the infant and the young child. It goes up to about when the child is able to walk independently well. So up to about a maximum of 2 years of age. For some kids it will disappear before that. And basically, if you start at the heel of their foot and take your finger up along the lateral aspect of their foot, you'll see their toes fan out and their big toe dorsiflex towards their head. That is significant because it's indicative of spinal thalamic reflex. So when we are not supposed to see a Babinski and we do, it's indicative of a problem with that reflex. And one of the problems could be, even though you can see it in a variety of illnesses, but it could be a tumor or a mass on the spinal column. And we can even see it in some of the infectious presentations as well. All right, asymmetry of reflexes may indicate injury, brain injury, or injury to an extremity. Clonus would be the rhythmic contraction and relaxation of a muscle when the wrist, ankle, or great toe is flexed. Again, you're going to see that more with the newborns as they just have very uncoordinated movements, but as the kid gets older, you will not see that as a normal thing. And then the cerebellar function. Cerebellar function has everything to do with balance. So anything you can do to observe their gait or assess their balance when sitting or standing, you want to do. And I know in one particular situation where you could see a disruption in this is with the child that's been diagnosed with a brain tumor. And that will be a new onset. That will be a change from a prior assessment. Or the parent will say, you know, I sat him up and he's able to sit up independently by himself, but as soon as I sat him up, he kind of tipped over to the side and fell down as if he couldn't control it. And that would be indicative of a loss of cerebellar function, as could be seen by someone with a tumor. Same with the baby that's walking, even a toddler. So we call we call their gait the toddler's gait because they kind of toddle back and forth, wide stance gait, and that's okay. But typically they can make it from one point to the next. If a kid starts having significant ataxia, they start out going straight, but you notice they're moving sideways as they're moving forward. That's a little bit more significant of a balance problem and could be indicative of a cerebellar mass. There's the Babinski reflex, again, that we talked about, that is normal in infants. The anterior fontanelle, again, part of your assessment when you're looking at increased intracranial pressure, if it's bulging, or on the sign of dehydration, if it's sunken in. It typically closes by as late as 18 months, but can close much earlier, as early as 9 months. Assessing the baby's tone when they're in resting position, and again, the younger babies are typically flexed. If you stretch their arms and legs out, they should typically come back in. Assessing for meningeal irritation, and this can be a little bit challenging if you're not used to being around babies and hearing what they sound like, but there's this cry that they have when they are irritable. It's a sharp, high-pitched shrill. It can make the hairs on the back of your neck stand up. And if you hear that kind of cry, you want to just pay a little bit more attention. We call it meningeal irritation, but you can see it with meningitis, encephalitis, or different types of abuse situations that cause increased intracranial pressure. Speaking now back to meningitis, you want to get into the history. Does this baby have a history of during birth having been exposed to group B strep or herpes exposure during delivery if it was a vaginal delivery? Those are the two organisms that are the highest causes of meningitis in the infant or neonatal, I should say neonatal population. There's also a Glasgow Coma score for children. We'll touch on that when we get to the picture in a little bit. And then you want to just talk to the caregivers about the history and anything that may have manifested that would indicate that this child has a regression or a delay in reaching their developmental milestones. Going on with assessment, there are different things we can assess when it comes to neurologic function. So one of the things, probably big important thing, would be brainstem reflexes. And the reason I said so important, because the brainstem, that's the midbrain, pons, and medulla, are the areas that are responsible for vital functions, basically. So doll's eyes, these are looking for these reflexes in a patient that might be unconscious, and we're trying to determine if they have intact brainstem reflexes or not. So for example, doll's eyes. If you have an unconscious person who does not have a cervical spine injury, you can open their eyes, open their lids, their eyelids, roll their head from side to side, and what will normally happen if the brainstem is intact is that the eyes would go in the opposite direction of the head. So if you're turning to the left, the eyes would go to the right. You should be concerned if you see that the eyes move in the same direction as the head is moving, or if they stay fixed in the socket. Oculovestibular reflex is also called cold caloric. So again, this would be an unconscious person. We're trying to see if they have intact brainstem reflexes. You instill ice cold water into the tympanic membrane. That is a fairly toxic, or I should say noxious stimuli. And by doing that, what's going to happen is their eyes are going to deviate to the side where you put the water in their ear. And then they'll probably have some nystagmus back and forth. If they have none, then you want to consider that it could be the brainstem is not intact. So there's just an example, a visual of doll's eyes reflex. and then we'll continue on with various meningeal signs. So we definitely talked about in the infant, the high-pitched cry, the irritability. Some of the other symptoms that would be more applicable to the older children are the obvious complaint of stiff neck, or what we call nuchal rigidity. You tell the kid to roll their head down and they won't do it because their neck hurts too much. Photophobia, pain with passive flexion of the neck, Brudzinski's and Koenig signs. I think I have pictures here to show these and demonstrate them. So Koenig sign is when the practitioner lifts the leg, puts the knee in a flexed position, and goes to rotate the foot. The person's going to have a lot of pain because that causes a stretch of the meninges. Brudzinski's sign is when you tell the person to lift their head and flex their neck, they're laying flat, they're going to automatically roll their hips in and roll their knees up, as a sign again of meningeal irritation. We can also go ahead and progress and check all of the cranial nerves in a pediatric patient, and it does take some creativity to do this. So for example, cranial nerve 5 and 7, so that would be trigeminal. So I think of trigeminal because the trigeminal nerve is called tri because it has 3 branches, but it's the 3 branches of the 5th cranial nerve is how I think about that. And then 7 would be the facial nerve. So you want to assess, are they able to blink? You're assessing corneal reflex as well. So you just take a cotton and rub it across their eye and see if they respond to that. You're looking for facial symmetry, which could be abnormal in something like Bell's palsy. We don't typically see Bell's palsy in young children, but you could see it in the older adolescent. The ability to raise the eyebrows, clench the teeth, smile, and chew. So that could be something where you just kind of say, I bet you can't do what I do. Or you try to tell them, please do what I do. Let me see if you can do it better. That might be one technique. Now, when checking for extraocular movements, I believe one of the best ways to do it with children is without them even knowing that you're doing it. So this could be a situation where you're checking cranial nerve 3, 4, and 6. And again, you're looking for extraocular movements. If they can follow your finger each direction, and also, okay. Also, if they can abduct as well. So you can tell them again to follow your finger inward, and you can bring your finger down and see if their eyes converge on each other on that finger. Okay, so that would be cranial nerves 3, 4, and 6, all for extraocular movement. You're also going to go ahead and do your pen light assessment and see if you see the pupil response to the light, where it constricts to light. All right, we didn't throw in here cranial nerve number 2, but we probably should, because cranial nerve number 2 is the optic nerve, and we would test that probably in older children, and it's tested by looking at visual acuity. So you would also always test cranial nerve number 2 anytime you have a patient that has a disruption in visual acuity. That's what we're testing. And in the ENT lecture, we have some variations of some visual acuity charts that can be used with children. Cranial nerve number 8 is interesting because it's not only for hearing. People recall it being mainly for hearing, but it's not only for hearing. It actually is also for balance, and that would be the acoustic nerve. So when we check that, we're looking at hearing, we're looking at balance, and that's a pretty easy one to assess by doing a variety of hearing tests, as well as playing games with some of the school-aged kids to see if they can balance very well. Tell them to close their eyes and hold their hands out. You know, put your arms around them but don't touch them. Tell them to close their eyes and see how much they sway. Those would be a few things you could do. Cranial nerve 9 and 10 is the ability to swallow, cough, and gag. And again, a school-aged child should be able to follow those directions. And then cranial nerve 11 and 12 would be spinal accessory and the ability to swallow. And so you could have the kids shrug their shoulders, tell them to not let you push down, you know, against resistance, see how strong they are. You can also tell them to turn their head to the side and push against your hand, see how strong they are. Some triage pearls when it comes to neurologic assessment or neurologic presentations. Things that would be considered urgent, emergent triages, where you just want to really level the patient and go ahead and get minimal data and get them to the main treatment area. Seizures that last longer than 15 minutes, or seizures that occur multiple seizures in a row. So the patient who has a seizure is postictal, does not wake up, and then has another seizure. That would be an indicator for an emergent triage. Glasgow Coma score of less than 12, indicates significant head injury and altered level of consciousness. Patients requiring pre-hospital medications for seizure control should probably be considered emergent. There's a reason why they needed meds, probably because the seizure was long-lasting. Otherwise, seizures are relatively short in children, and they become postictal, and that's it. Altered mental status after a first-time seizure. And again, this you kind of have to take with a grain of salt, because this probably needs to be incorporated into not necessarily during the postictal period. We need to give them some time to not be postictal. An incapacitating headache in a patient with a shunt or in a patient with hypertension, and we're going to tie that in closely to AV malformation, slurred speech, or facial asymmetry. So basically, an incapacitating headache with any other focal symptoms should be considered an emergent. Everything else neuro is considered urgent. All right, we'll talk about the concepts of intracranial pressure and cerebral perfusion pressure. So intracranial pressure is really looking at the pressure of the ventricles and the system that actually circulates CSF, cerebral spinal fluid. Normal would be less than 10, but there is some allowing for just normal variations. So typically we won't treat just an ICP until it goes over 20. And we'll talk about those conditions that might lead to an increased intracranial pressure. Cerebral perfusion pressure, on the other hand, is a measure of the perfusion of blood into the brain. So it's really looking at cerebral vasculature and cerebral perfusion. Now we can calculate cerebral perfusion pressure by looking at the mean arterial pressure, which again is sort of a reflection of the systemic arterial pressure. And then we subtract from that the intracranial pressure. And what we're left with is the cerebral perfusion pressure. So we give you the normal parameters there in young children and in school-age adults. Increased ICP. We have some symptoms that are very clearly associated with increase in intracranial pressure. And again, typically you're going to see this increase with conditions where there is a head injury, or the person has something like a shunt, so they have a pre-existing problem that there's something that goes wrong with that shunt, that it's not doing what it's supposed to do. We have early versus late signs. So with your early signs, their speech is a little bit less distinct. They may be just restless or anxious. They may have some balance issues such as a pronator drift, and their pupils react, but it's a sluggish reaction. Later signs would include arousals only to deep pain, the person who's completely unarousable, pupils that are not responding, either fixed and dilated or pinpoint, but typically fixed and dilated represent increased intracranial pressure. Posturing, and then Cushing's response, and we'll talk about both of those. With posturing, we have decorticate, which is the picture on top, and decerebrate, which is the picture on bottom, posturing. And typically what is happening with either of these, you only see them with increased intracranial pressure or conditions that can lead to herniation. And so what's happening is they bring the arms up and rotate them in with decorticate towards the core, down and rotate it out with decerebrate. And the feet do the same thing. They basically have plantar flexion and with the feet on both of those. Either way, it indicates that this is an abnormal functioning of the brainstem, basically. Neither one of them are good. So I know the question says which one is worse, but I want you to consider that neither of them are particularly good. And if you have them, this person is unconscious, basically. You could also have a person who's posturing unilaterally on one side of their body, and if I see that, I always think and wonder, is the other side paralyzed? That could be an indication. So again, we know that posturing is an indicator of injury to the brain stem, and that's the midbrain, pons, and the medulla. And in theory, I guess decorticate is not as bad as decerebrate because it indicates that the damage is a little bit higher in the brainstem as compared to decerebrate, which is meaning the damage is probably to the medulla. And at that point, they're going to have vital sign changes as well. When we talk about herniation, we basically are talking about an extension of or a progression of increased intracranial pressure. Now, what I want you to think about with herniation is that your cranial vault does not allow for anything to really go wrong. If you have alterations in your CSF, your ventricles are too big, your brain really can't compensate for that. There is no space. If your vasculature goes all wrong and you start bleeding into the brain, there is no space. If you have a mass that develops in your brain, there's very little space for brain tissue to accommodate that. So what ends up happening is you have a shifting of tissue. And that's truly what herniation is, and we've already mentioned some of the etiology of that. All other signs and symptoms of herniation are usually present to some degree, and that would be altered level of consciousness, posturing, and vital sign changes, specifically Cushing's triad, which we'll touch on in a moment. But you have something called uncal herniation and then something called central herniation. There are other types of herniation, but these are the two common types that present in settings like the ED and that are commonly tested on this exam. So uncal herniation is shifting of tissue from one side to the other and typically results in dilated pupils. It can be unilaterally or bilaterally, but typically it's dilated pupils. Central herniation is pushing of brain tissue down and forward, or down into the brain stem. And typically that is accompanied by or manifested by constricted pupils, and it is bilateral. So I always think of central herniation, central starts with a C, constricted pupils, constricted starts with a C. It's how I memorized which one was which. We've mentioned Cushing's triad a few times, so now we'll just touch on it. Again, this is an extension of a sign of increased intracranial pressure. It is considered a late sign, and what I mean by that is at this point you are putting pressure on the medulla, and since you're doing that, you're having these vital sign changes, and the vital sign changes include increased systolic blood pressure and or a widened pulse pressure. So their blood pressure may actually stay where it is. Maybe it's 128, which we may not think is very increased. But if the diastolic goes down to 28, that's huge, and there's a problem. Typically you see a relationship where diastolic is 2/3 of your systolic. They will have profound bradycardia, and then any type of abnormal breathing pattern. So it could be Cheyne-Stokes, it could be Kussmaul's, it could be Biot's breathing pattern. Any abnormal respirations coupled with the blood pressure changes and the profound bradycardia are indicative of Cushing's triad. It is considered a late sign of ICP, and we need to be acting quickly. In patients with increasing ICP, after a closed head injury, fixed and dilated pupils result from increasing pressure on which of the following cranial nerves? And that would be cranial nerve number 3, oculomotor. Pupils constriction occurs. It controls pupil constriction and dilation. So if we're saying that the pupils are fixed and dilated, that's going to be cranial nerve number 3. The C, option C, the third choice, says cranial nerves 2 and 3. So the problem with that is that cranial nerve 2 is optic, and that's controlling visual acuity. So it's not going to be the pupil issue, which is what it's reading in our stem. Okay, cranial nerve number 5 is trigeminal, has to do with the face, not so much the eyes. And then cranial nerves 4 and 6 have to do with eye movement, not necessarily pupil movement. An intracranial pressure monitoring device has been placed in an unconscious patient. The ICP reading is 15 millimeters of mercury. In order to maintain a cerebral perfusion pressure of 80, the emergency nurse should evaluate the patient's MAP, mean arterial pressure, and keep it maintained at, so the answer here would be 95, because remember your CPP is, the formula for that is MAP minus ICP. So if you have an MAP of 95, subtract 15, which is the ICP, you'll come up with the CPP of 80. Now we'll talk about some medical, surgical, and traumatic emergencies related to the neurologic system. I start off with hydrocephalus. As we know, this can be seen in neonates from birth. It can also occur after head injury. And problems that we see typically with people who have hydrocephalus are related to the shunt that is subsequently placed. The shunt is placed to drain fluid, CSF, from the ventricles into either the right atrium or into the abdominal cavity, the peritoneal cavity. With hydrocephalus, you can have multiple situations that lead to that end. It could be overproduction of CSF, inadequate reabsorption of CSF within the meninges, or an obstruction in the flow of CSF. The treatment again is a shunt, and we show the different areas where you can have that shunt drain. Assessment of the person with a shunt. As you can see, this is a great picture to identify how the catheter goes from the ventricles to the reservoir behind the ear and then down the catheter and drains into one of those areas, either the right atrium or the abdomen. Typically what we see with people who come in with shunt malfunction or shunt infection are these symptoms: the vomiting, the headache. And vomiting with a headache or with any neurologic presentation is always cause for alarm, and always, to me, makes me think of increased intracranial pressure. Inconsolability, irritability in the infant, pupil changes, sunset eyes are particularly seen with hydrocephalus, and basically you can even see it in this picture a little bit. It's where you can see the sclera above the eye, above the color portion of the eye. So, and that's called sunset eyes, and that is seen with hydrocephalus. High-pitched cry, if they have a fever, redness along the shunt line, or pain around the shunt reservoir, that could be an indication of shunt infection versus just shunt malfunction, which typically shunt malfunction we think of as an obstruction. All right, so then we separate out the symptoms of fever compared to obstruction. The diagnostic evaluation of both is going to be the same. We're going to do a shunt series. A shunt series is a series of x-rays. They're going to x-ray the skull, the cranium, the neck and chest, and then the abdomen. Basically, what we're looking for with the x-ray is that all the shunt pieces are there and are in place where they should be. You're going to do a CT and or an MRI, and this is going to be to look at the ventricle size, and we could also do comparative if we have the child's records. A practitioner may also consider doing a shunt tap, in which they actually take CSF from the reservoir of the shunt. They just use a butterfly needle, go right in, pull some fluid off, and send that off to the lab. Of course, we're going to do our BMP and our blood culture as well, especially if they have infection. We want to elevate the head of the bed. If there's a chance of infection, we're going to go ahead and give antibiotics, analgesics for their pain. We may also do medication that helps to decrease the ICP, such as an osmotic diuretic, such as mannitol, and of course control their fever. Seizures. So we know seizures can be a very common presentation seen in children, and it could be someone who is already diagnosed with a seizure disorder. It could be the child who has something else happens and the seizure is the result, such as ingestions or trauma. And it could be the kid that comes in with the most benign of seizures, which is the febrile seizure. So we know that seizures are a transient, abnormal, excessive electrical activity of the central neurons, and the location in the brain and progression of the discharge of those neurons varies. And we further break down seizures by identifying whether it affects the entire brain or only part of the brain. So we have primary generalized, and then we have partial focal. Under primary generalized, we have the absence seizure and the febrile seizure, and I picked out the ones that were very specific to children. The absence seizure was formerly referred to as petit mal seizures. This kid actually does not have the psychomotor movement that we typically see with a tonic-clonic seizure. Instead, they just are not with you. They just kind of have a loss of consciousness. But you may not know it because their eyes might actually be open and they're staring off. We see typically this is reported from school teachers who see children that kind of just look like they're in a fog and they're not there, and they stare off. They may actually lose consciousness and close their eyes, but they typically don't have any psychomotor movement that goes along with that. And then we have the febrile seizure, again specific to children. It's considered a type of provoked seizure because typically it occurs with the fever. We think it happens because their brain is fairly immature and the fever goes up at such a quick rate, the brain doesn't have any chance to really get used to it or accommodate it. So then they have a generalized tonic-clonic seizure. This does not typically lead to long-standing seizure as they grow up, and sort of the kids will grow out of it, we like to say, if it's a typical febrile seizure. And also when they come into your emergency department, if you can find a source for the fever, if the seizure described was very typical of a febrile seizure, so short in duration, tonic-clonic, postictal, not very prolonged, the kid wakes up and they're with it. You find a source of fever, that's it. The kid doesn't need a $1 billion seizure workup. They can be sent home with some antibiotics if that's what they have, an infection that can be treated with antibiotics. And that's it. They can follow up later on with neurology. All right. So again, we have the tonic-clonic movement. The tonic is the stiffening. The clonic is the jerking. We describe status epilepticus as a seizure that is prolonged, greater than 30 minutes of seizure activity. Or remember, seizure that recurs, but the child never went back to their baseline. So the kid that was postictal and seized again, but they never woke up. Now the problem with status epilepticus that we are always very aggressive at managing is that it can lead to mortality from severe acidosis, hypoglycemia, autonomic dysfunction, and hypercalcemia, which we know can lead to muscle as well as heart dysfunction. We definitely want to observe the child during and after the seizure. Observing during the seizure is important because it can actually help to diagnose what type of seizure this kid is likely having. So we want to know how they respond to stimulus. Are they able to follow commands? Did they have an aura or a prodrome prior to the seizure? Now this may or may not happen with us, and even if it does, we may not notice it. But the care provider will notice if they've done something different, or every time they have a seizure they do the same thing. We describe tonic and clonic movements. Of course, they may have eye deviation. A lot of the kids do have incontinence with their seizure. And then, of course, the postictal state where they may complain of headache. They may have an amnesia, and they typically are a little bit drowsy. As far as diagnostic tests go, we want to monitor drug levels. So what we mean by that is any child that has an existing seizure disorder, we want to draw their levels to see how they're responding to their meds, because obviously if they're having breakthrough seizures, their meds are not working. In addition, we want to do a CT scan or an MRI to look for, again, causes for the seizure, if there are any masses there or inflammatory processes. An EEG can be done on follow-up or part of your emergency department workup. EEG is going to put the electrodes all over their head, try to invoke a seizure to see if we can figure out what type of seizure they're having. If we suspect that this seizure was related to an infection such as meningitis, they're going to get an LP. We're going to pull from some CSF and send that to the lab. And then, of course, your myriad of electrolytes that can cause seizure activity, such as sodium problems, hypo or hypernatremia, we want to look for, as well as your tox screen to see if there's any toxic substances that this child may have gotten into. As far as treatment goes, we're going to focus on safety. So you're going to do seizure precautions for the most part with this child. And then we're going to really focus on what medication administration we're going to do, what pharmacologic intervention. So there's two ways we're going to go. First and foremost, we need to stop the seizure. And we stop the seizure by giving a benzodiazepine. Secondly, we want to prevent them from having another seizure. So we're going to do that by loading them with an anti-seizure drug, such as Dilantin, phenobarbital, phosphonatoin. There are so many options available. Guillain-Barré. This is an acute inflammatory polyneuropathy that primarily affects the motor component of the peripheral nerves. We don't know exactly why it happens, but it is considered to be an immune-mediated response that triggers the destruction of the myelin sheath, and then you have where the motor component of peripheral nerves are not going to conduct movement, basically, are not going to trigger movement. So we see this in older adolescents. So it peaks at about 16 to 25 years of age. 50% of those patients had a mild febrile illness 2 to 3 weeks prior to coming down with the symptoms. The symptoms are fairly classic. Think of GB, ground to brain, is what I want you to think of. Guillain-Barré, ground to brain, because that's how the weakness progresses. It starts in the periphery or in the lower extremities. It progresses symmetrically, encompassing the entire extremity, circumferential, and moves upward. The motor function will return in the descending manner that it came. The motor weakness or paralysis can last for a few weeks, and it can progress to their respiratory muscles, resulting in them needing intubation and ventilatory support. So we know they can have respiratory insufficiency, and in addition, they can have urinary retention, as they have some of the autonomic dysfunction symptoms. Diagnostic tests are primarily done to rule out anything else that may cause similar symptoms. There is not really one diagnostic test that's going to be used to prove that it's Guillain-Barré. The treatment includes monitoring their respiratory status and acting early if they show signs of muscle weakness or impairment with the respiratory muscles, pain management, and of course emotional support. Reye syndrome is the etiology of Reye syndrome is actually unknown. So Reye syndrome is just that. It's a collaboration of symptoms and situations that present themselves the same. If we see them over and over again, we can reproduce them. And typically what that situation is a child that has had a recent viral illness, and during that time they were treated with a salicylate product such as aspirin. So that's number one. Shortly after that, they developed altered mental status and liver dysfunction. So it's that combination of things that lead you to believe it could be Reye syndrome. The liver dysfunction is a result of fatty deposits in the liver, and that will then lead to the altered level of consciousness as the ammonia levels rise. They also will get hypoglycemic, which we know children are very glucose dependent and cannot tolerate hypoglycemia very well. They'll become lactic acidotic. They'll go into a phase of lactic acidosis and get metabolic acidosis. All right. So the biggest thing we can do is probably decrease the use of or eliminate the use of aspirin in children. And since we have done that, we've seen very few cases of Reye syndrome at all. The goal for therapy is going to be basically to treat their hypoglycemia and to keep their ICP within normal limit. There is no one treatment that really takes care of Reye syndrome. So, and there's the treatment there at the bottom, and the progressive symptoms as well. Meningitis and meningococcemia. Meningitis can be either viral or bacterial etiology, and we listed a few of the things that commonly cause meningitis in children. Meningococcemia would be a septic presentation of this, and typically is caused by Neisseria meningitidis. It gains access into the bloodstream and causes sepsis. Diagnostic testing that's going to show it's meningitis is pretty straightforward. They need an LP. So you could get questions about how to do an LP on an infant versus on a child, because the big difference is the positioning. With infants, we're going to have them sitting up with their chin tucked into their chest and their hips tucked, rolled in, bring their feet in as well. Obviously, if you're going to hold an infant in that position, they should probably be on a pulse ox so you can look at their oxygenation during the procedure. For children, we're going to put them side lying with, again, the knees up into the chest and the chin to the chest, or knees up and tucked into the abdomen and chins to the chest. Obviously, they're going to be entering at about the level of L4, L5, so that's where you want to put your anesthetic so that the child is comfortable. And when they get the CSF, they're going to send it to the lab and look for a few things, which you'll look at in a minute when we look at diagnostics. It can be used to diagnose hemorrhage, infection, and obstruction. So we mentioned the CSF, so I'm actually going to look at the right side of this slide first. The CSF, when it's bacterial meningitis, has a very characteristic appearance and look and evaluation on the lab when the lab looks at it. Number one, it's going to probably be cloudy. It may even have things floating in it, which we know CSF should be clear. There should be nothing in it. It's going to have elevated WBC, elevated protein because bacteria are protein-bound organisms. And it's going to have decreased glucose because in order for bacteria to stay alive, they have to utilize the glucose. Viral, on the other hand, the CSF is going to be clear. It's going to be normal protein, normal glucose, but they may have elevated lymphocytes and slightly elevated WBC. The symptoms that accompany meningitis, again, are pretty straightforward. The nuchal rigidity, the photophobia, the phonophobia, the headache, lethargy, irritable, inconsolability, bulgy fontanelle on an infant, poor feeding on infants. And then again, if you're worried about meningococcemia, we're going to really look for that petechial type rash that can become purpuric. And typically we see it below the nipple line. And this is a great picture of what it can progress to. Okay, these characteristic purpuric lesions of meningococcal meningitis. This person is definitely septic and at risk for losing that foot. Management is going to be aggressive and early antibiotic initiation. And if you suspect that it's meningococcemia, we might even be doing prophylactic antibiotics for anyone that child has been around in the last 24 to 48 hours. Antipyretics, we're going to constantly monitor their neurologic status. They are at risk for seizures. Doing things that will minimize their ICP. So no coughing, no straining, cut down the bright lights, no aggressive suctioning if needed. And then again, just the antibiotics primarily. So encephalitis is an acute inflammatory process of the brain tissue. And we see the highest incidence in this in children less than 10 years of age. And typically see it in other countries as well, not so much in the U.S. It can be bacterial, viral, protozoan, or fungal, and it can also be a complication of other disease. Some of the childhood diseases that, in theory, we treat for because we immunize. But when children don't get immunized, they are at risk of getting some of these more complicated diseases. In addition to measles, it also is a consequence. Encephalitis is a consequence of chickenpox as well. So symptom-wise, they're actually going to present like they have meningitis. The thing is, their symptoms tend to be very much more acute compared to meningitis, and they may also have behavioral change as well. We want to assist with an LP. We're going to do pharyngeal and swabs and cultures of everything. We're going to do antibiotics if we suspect that it is bacterial. And really we want to talk to caregivers about prevention. And one way to prevent would be to prevent some of the bugs, such as mosquitoes, that can pass on encephalitis. So people should use DEET when they go out in areas that are mosquito endemic, for example. All right, headaches is an etiology. Headaches we do see quite a bit in our adolescent population, but you can also see it, especially as stress is increasing for these school-age kids, in the school-age range as well. So the different types of headaches that we typically see would be the tension, the sinus headache, which is also considered inflammatory, and the vascular headache, which could be included in or considered as the migraine headache. All right, you also can see cluster headaches, but we just don't see cluster headaches as much in children. You typically see those in adult males. Tension headaches, the person's going to describe that they have a headache to the entire head and it radiates down the neck. And almost always you can attribute this to some type of stressful situation that the teen is in, that the adolescent is in. Inflammatory headaches such as sinusitis, can be seen definitely in children as well. And the problem with those is that it can definitely lead to, sinusitis can lead to intracranial abscess, meningitis, encephalitis. So you really do want to pay attention when a kid is complaining of a headache and has sinus symptoms. We want to get them evaluated, make sure they don't have true sinusitis from a bacterial invasion because that would require antibiotics. Okay, and then the vascular headache, increased intracranial vasodilation or arterial dilation. So the migraine headache is fairly classic. We do see this quite a bit in adolescents, and probably more in young girls than in boys. But the pain is very classic. They're going to have severe throbbing pain, either the frontal area or the frontotemporal area of their head. They can tell it's coming. They'll tell you, I felt this headache coming for the last 2 days. They may have phonophobia, photophobia. They may have nausea and vomiting. Some kids even have an aura. We call it scotoma, when they have a visual aura that they have before the headache starts. And they could have some transient neurologic deficits as well, all from a migraine headache. All right, vital signs may be normal, but also they can have hypertension, which again should raise an alarm when you see this in a kid. Meningeal irritation, papilledema, checking their visual acuity because it may be altered. Assess for sinus pain. Make sure it's not really a sinus headache presenting as a meningitis. And then general management of headache is going to be dependent on the type of headache the child is having. So again, if this headache is from a stress-related headache, what we call a tension headache, you really want to do more talking with the child and try to help them to identify their stressors and deal with them appropriately. We do want to darken the room and minimize any stimuli because that may help as well. With the sinus headache, again, they're going to need anti-congestants and pain management and antibiotic. The decongestants should really help with the pain as well. With the migraine headache, on the other hand, we are going to focus on narcotic analgesics in the emergency room. Or for the younger children, we may just focus on Tylenol and ibuprofen for the younger kids. As far as the kids going home, we may try to teach them about some of the medications that may help to minimize the progression of the headache if they take those meds as soon as they feel those headache symptoms come on. And that would be with some of the triptans that we can give. Now we'll talk about some of the trauma presentations, starting with skull fractures. So the different types of skull fractures would include linear and depressed skull fracture. There are others, the basilar skull fracture as well. The linear skull fracture accounts for most head fracture seen as a result of trauma, and is typically due to low velocity trauma. Depressed skull fractures typically occur when an object hits the head and displaces the bone downward. Typically, this is the result from high velocity trauma and often requires some type of surgical intervention. The basilar skull fracture is just that, and involves the base of the skull, particularly the anterior or middle fossa. And again, this typically can occur from full frontal blunt trauma, and it almost has to be a hit right in the right place in order to have that type of basilar skull fracture. Now, the basilar skull fracture comes with lots of complications. You could have CSF leaks, and we'll show you how that can happen from this picture. You can see on the top diagram or picture, the basilar skull fracture is going to result in rhinorrhea, as there's going to be dripping of CSF through the nose. And on the bottom figure, it's going to show you how, based on where the basilar skull fracture is, this person is going to have otorrhea, where the fluid is dripping out through the ear. If you're not sure what's coming out secondary to someone having a fracture, you think they have a basilar skull fracture, but maybe there's blood coming out and you're not sure if there's some CSF in there, we can do something called the halo sign, assessing for halo sign. So you allow a drop of blood to fall on a piece of cotton. It doesn't work very well on gauze because gauze is too absorbent. It almost works best on a sheet. But I don't want to tell you to ruin all your hospital sheets looking for this. But basically what you do is wait and see if the CSF separates out from the blood around the edges. It may also be a little bit yellow. All right, the person may actually sense a taste of sweet or salty in the mouth if CSF is dripping into the back of the throat. They may also exhibit what we call battle sign and raccoon's eyes. So obviously raccoon's eyes is about bilateral ecchymosis around the eyes. Battle sign would be the mastoid ecchymosis. And typically the mastoid ecchymosis does take time to occur. So if you and I see it in the emergency department, it probably means that this person has a significant bleed or they've been without care for a while, walking around with this basilar skull fracture. Diagnostic tests are going to include your CT, your MRI, your skull films, obviously testing any drainage for glucose, clear drainage anyway, because that could tell you that it is CSF. And then treatment is going to be dependent on the type of fracture they have and also on their presentation. We can use drip pads for the CSF leaks, but you definitely don't want to insert anything in their nose or ears if you suspect that they do have a basilar skull fracture, because you could be trapping bacteria in there. We're probably going to give them some anticonvulsants, put them on seizure precautions, give them antibiotics, and pretty much the rest of the treatment will be based on how they present. All right, so we have focal brain injury, so this would be intracerebral hemorrhage, bleeding within the cerebral tissues as a result of shearing of the small, deep vessels of the brain. So clinical manifestations of this, pretty straightforward: unconsciousness, some type of hemiplegia or paralysis, dilated or ipsilaterally dilated pupil in a normal pupil. Treatment would be focused on the presenting symptoms, focus on keeping ICP down. So again, giving the mannitol, minimizing doing things that would increase ICP. And then of course they may be going to surgery to evacuate the hemorrhage if necessary, if it's large enough. All right, we have our subdural hematoma, which is a collection of or accumulation of blood between the dura and matter and the arachnoid layers. Typically, the subdural hematoma is seen with a linear skull fracture to the temporal region, and is typically a venous bleed, which means that the symptoms are going to be a little bit more insidious, not as rapid progressing. There are various ranges, which would be acute, subacute, and chronic. And the clinical manifestations do include, again, headache, drowsiness, agitation, and more of a slow deterioration in their LOC. They can have pupil changes as well, and they can have hemiparesis. Surgical evacuation may be an option if it's a big bleed. ICP monitoring and management and prevention of increased ICP is going to be important, as well as preventing seizures. And again, preventing seizures also goes along with minimizing or preventing ICP. Now, the epidural bleed is a little bit different. This is bleeding between the skull and the dura. And typically, this comes from a laceration to the middle meningeal artery. So this is an arterial bleed. So the presentation's completely different. These people are unconscious after their trauma. Then they wake up, and they're actually with it. They have a lucid period, alert, oriented. But then that is followed shortly by a deteriorating level of consciousness, nausea, vomiting, restlessness, pupil changes, seizures, or just full arrest. I've actually seen patients go into full arrest secondary to an epidural, where minutes later they were awake and alert and talking. Bottom line for this is surgical evacuation. All we're going to do is stabilize them to get them to the OR. This is just showing you herniation basically, and how the midline is so shifted from one side to the other with a patient with an epidural who has a large bleed. Cerebral contusions are bruises to the brain tissue. Typically happens in the frontal or the temporal lobes, again from blunt trauma. These patients will have altered level of consciousness. They may have some level of amnesia. And again, they may have an insidious onset of increased intracranial pressure, which would give you the same symptoms that we've pretty much mentioned. You want to do serial neuro exams on these patients and prepare for, again, keeping their ICP down, possibly ICP monitoring, and again, if the contusion's big enough, surgical evacuation. Concussion would be a traumatic reversible deficit resulting in temporary loss of consciousness and some amnesia. So this person may have amnesia also. Typically we see this from a strong rapid acceleration deceleration force injury or a sudden blow to the head. It can last from minutes to hours to days, And typically, again, you'll notice some of the same symptoms from some of the other head injuries: the altered level of consciousness, the headache, nausea, vomiting, dizzy, amnesia. Interesting with kids, you may not be very aware that they have amnesia unless you interact with them. I had a kid one time, he was about 8 years old, and he was completely alert and oriented with clear speech. He had run into the wall during gym at school. And they said he hit the wall so hard, he bounced back and fell out. He woke up. He seemed to be alert, complaining that he has a headache, where he had a big bruise on his head. When he came in, the kid had a steady gait. He would have totally passed a neuro exam if I had not talked to him. I asked him a few questions. His mother wrote down what the complaint was: amnesia after head injury. And basically what he would do is turn around and look at his mom and ask her the question, and then turn around to me and tell me the answer. But the questions I were asking him were things that, you know, he should have known. How many brothers and sisters do you have? And he would turn around and ask his mother, did you go to school today? He had no idea. He could not remember anything. And the more I asked, the more the mom's eyes just welled up in tears. So I finally figured the kid's really got amnesia. But again, if I hadn't done that assessment, I would have never believed that this kid had a significant head injury, because he looked so normal and without any deficit. Very briefly, we're going to cover spinal cord injury. We know that the main group that is affected by this are our adolescents, and obviously trauma tend to be the major cause, and it's falls, motor vehicle crashes, gunshot wounds, and sporting accidents. So we're talking about both penetrating wounds to the spine and blunt trauma to the spine. Now, the mechanisms can include axial loading, which is typically what you see with your dive incidents, and cervical spine injury, hyperflexion or hyperextension, and these are going to be more typically seen with your motor vehicle crashes and with your sporting accidents. SCORA is not really a word, and it is an acronym, and it stands for spinal cord injury without radiographic abnormality. This is a phenomenon that is seen in children where they present like they have a spinal cord injury. They may be paralyzed bilaterally from the legs down, right? But when we look at their scans don't show any bony malfunction. That doesn't show any significant thing with the spinal cord. So they have a spinal cord injury, but we don't see any radiographic abnormality. But again, when you see how they present, it definitely is as if they have a spinal cord injury. So we've isolated out the different areas of the spine that innervate certain areas of our body, so that when you're doing your assessment, you can pretty much figure out, based on your limitations of your patient, where their injury is about. So I just want to bring your attention to one area, which would be, let's see, T1 through 7, because that is where the chest muscles, the ability to cough, and deep breathing would be affected. So anything above T1 through 7 is probably going to have some respiratory dysfunction, so you need to be able to provide that support. All right, we see an acute response after spinal injury, and that is referred to as spinal shock. It occurs immediately after the injury, and it can last for hours up to weeks. Basically, the patient is going to present with paralysis, decrease or loss of reflexes, alterations in temperature, touch, proprioception, pain, and pressure sensation below the level of the injury. They may also have absent or impaired thermoregulation, and that is considered spinal shock. Is a phenomenon seen immediately after. Now, you also have neurogenic shock, which is now referring to their hemodynamic status. So spinal shock was really talking about the spinal cord and the symptoms that we see as a result of that, whereas neurogenic shock is a hemodynamic problem. So they have hypotension and bradycardia. I always say that neurogenic shock to me is one of the easiest shocks to identify, because it's the only one that has signs of decreased perfusion, hypotension, but they're bradycardic. All the other shocks, the first compensatory mechanism is tachycardia. But with neurogenic shock, because you lose the sympathetic innervation, they lose the ability to increase their blood pressure, because that's what your sympathetic nervous system does for you. So they end up having bradycardia. The parasympathetic system takes over, and the symptom of that is bradycardia. They lose vascular tone, and again, you have a cessation of spinal shock, the return of anal reflex and bulbocavernous reflex as well. With neurogenic shock, we're pretty much going to treat, again, as a hemodynamic problem with atropine to increase their heart rate, as well as vasopressors. All right, with spinal cord injury, obviously you're going to assess the mechanism of injury compared to the neural deficit seen, respiratory ability, because that can give you an idea of how high up the spinal cord injury is, motor and sensory function. We're going to look at both. And you really are going to have to identify what sensory function the kid is or is not having, because kids may not be able to describe to you the difference between numbness, tingling, coolness, prickling, things like that. Management is going to focus on obviously the symptoms. So if they're having respiratory symptoms, of course, we're going to maximize oxygenation, ventilatory support. And hemodynamic challenges, we're going to address those from a hemodynamic treatment standpoint. Steroids are still on the plate as an option for treatment with spinal cord injury. And again, obviously just kind of treat the symptoms as they present. I did include the methylprednisolone protocol. Some hospitals are still doing this for spinal cord injury. Remember, you would never do this for anyone with a penetrating injury. We would never do it for any person that has spinal cord injury during pregnancy, or for someone with cauda equina lesions, and those lesions are very, very low, so we wouldn't do it for those. Autonomic dysreflexia is actually a condition that can be seen with a spinal cord injury that's already been established. So it's not really seen in the acute phase of a spinal cord injury. So this might be a patient that is a quadriplegic or paraplegic from some other incident. They come into your ER for something, and they develop autonomic dysreflexia. Typically what happens with autonomic dysreflexia is they have a noxious stimuli, and the noxious stimuli could be a bladder that's enlarged with urine, a rectum that's full with stool, or pressure on a decubiti. And all of those things basically cause an overreaction of the sympathetic nervous system. That leads to, again, sympathetic nervous system symptoms that go into overdrive. So they get a sudden onset of a severe headache. They will have severe hypertension. They will have flushing and sweating above the level of their injury, coolness below the level of their injury, and they'll have some dysrhythmias. So what you want to do immediately is raise the head of the bed, loosen any restrictive clothing, and try to find out what put them in this situation, because if we can alleviate that, it will take the symptoms away. We may have to catheterize them. We may have to evacuate their bowel of stool, or you may have to simply just remove them and move them from the decubiti ulcer, the pressure on the ulcer. We also do end up treating their blood pressure as well. And then finally, AV malformation. So AV malformation is so interesting because this could be a kid that's walking around for years and has occasional headache or frequent headache, but you know, it's never bad enough to really do anything about. They could be completely asymptomatic. It could be a kid that just goes through various visual changes, but their visual acuity is actually fine when they go and get tested. But the problem here is because there is basically it's a direct connection between the arteries and the veins. There's no capillary system. So that's a problem because the arterial system is such a high pressure system. And you cause high pressure in the venous system, which then leads to their symptoms. We don't really know why it happens, but it actually happens during embryonic development. It's just that some kids make it really far in life before they realize that they have this. If they have hypertension, that will definitely complicate their symptoms and may lead to an earlier diagnosis. Once it is diagnosed, we know they're at risk for bleed, basically, because of the anatomical and physiologic differences, changes that occur. But once we actually diagnose it, we try to manage their hypertension to ensure that they don't become hypertensive, because hypertension can now contribute to a bleed. So that's AV malformation. Thank you very much for joining me for Neurologic Emergencies.